cultura da cidade Rio de Janeiro, por abrir as portas para nós, para poder fazer o que nós fazemos. Nossa missão foi estabelecida como organização, não somente como hospital, já há mais de 100 anos, 110 anos, com uma missão muito clara, que foi construir pontos para a paz através da saúde e da medicina. Construir colaborações, construir espaços onde a gente pode trabalhar juntos para conseguir melhor saúde para a gente. E no contexto de Jerusalém, isso tem construir pontos para a paz, começa na casa. A casa, que nesta casa, é nosso hospital, como na América.
My son has been in Jerusalem and Tel Aviv last month.
You?
For tourists, my son. He lives in London.
Tem também os desafios agregados de situações conflitivas em uma parte do mundo das mais conflitivas cidades onde se concentra tanto desafio, não problema. E para poder fazer toda esta construção de pontos para a paz, de pontos de saúde, recorremos o mundo explorando oportunidades de compartilhar o conhecimento, o know-how do hospital, a experiência, os modelos que doutores como o Dr. Ahmad vão construindo todo o tempo. O DNA, o ADN do hospital é basicamente gerar inovação para trazer soluções não somente para a medicina, para grandes drogas que sejam novedosas para trazer cura, sino também para gerar acesso no mundo para esse tipo de tratamento. Essa combinação de atenção humanitária e também atenção para específico de cada problema, de cada doença. Por isso, para mim, é um prazer presentar ao Dr. Ahmad Nama, quien es el director de emergencia del Hospital Adasa en Cairo, en Jerusalén. También estudió fuera de Israel, estudió en Australia, estudió en Europa y con sus 37 años es el director de emergencia más joven en la historia de Israel, que es un país joven. Mas realmente un ejemplo de trabajo basado, como palabra, en innovación, en ideas nuevas también para llegar a lo que es importante, que es no solamente curar, sino también poder curar a mayoría de gente posible. Doctora Fontana, por favor.
I have one. Hello, good afternoon. Can you hear me? Can you hear the mic? Hello. So, first of all, I'm really excited and I'm happy that I am here. It's my first time in Rio, in Brazil. Actually, we landed yesterday, and we arrived like 3 hours ago, and it's my pleasure to be here. I just want to say that it's not a story or a presentation about a hero. I'm not bringing something that it's out of the sky, some stories around, and just bringing some experience that we have been experiencing at Hadassah Hospital, at my institute in Jerusalem. And of course, I'm really sure that the volume of the patients that you have here in Brazil, in the hospitals, the huge numbers that you have here as well, it's also, I'm sure that we can learn definitely something from you. But of course, I'm here. I'll be happy to share our experience. We are going to just go quickly through introduction, defining emergency medicine, and a little bit go about the specialty in emergency medicine as well. How did we manage to have emergency medicine specialty in the last few years in Israel, and some of the challenges, and a little bit probably touch the smart emergency medicines, or where we see our future. So I'm not sure if you are familiar with Hadassah Hospital. Hadassah, it's one of the major hospitals in Israel. We are in number 5 or 6 as in patients bed. We have 1,300 beds. It's a community hospital. It's a university hospital, meaning that the faculty of medicine, dentistry, pharmacy, and nursing, it's an integral part of the hospital. There is a famous one door that separates the hospital from the university. It's something unique in Israel, at least. So it's the only hospital where the university is inside the campus, it's inside the hospital, and our staff, doctors, mainly are part of the academy. So if you want to progress and proceed in your academic career, you have the opportunity. Usually, this is where the hospital, where is the university, is pushing forward. We have a trauma level 1, a tertiary medical center. It's one of the first established trauma centers in Israel since 1990. Also a referral center for, it's not a military hospital, but it's a referral center for military in case of any crisis. So we are a hospital that the military can use and can refer to us patients in need. And we are a country-wide hospital for all over Israel. It's a little bit famous. It has a prestigious about the high quality of care, and we regularly have transfer patients from many institutes to our institute, including international. We have an international department, and including daily basis. Also in the emergency department, we see patients coming from the Palestinian territory as well. So it's a big hospital. We have all the facilities regarding PET, multiple MRIs, angiographies, of course, neurosurgery. We have a big oncology center, and we have all the departments facilities as well. We have 2 campuses. So the Ankarim campus, this is the campus that I am the director of the emergency medicine department at Ankarim campus, which is the bigger campus. We have also the Mount Scopus campus. It's a little bit smaller. We don't have all the facilities there, but regarding trauma, we did something new 2 years ago. We have a new trauma, 2 beds, high facility trauma beds. In case we have received trauma there, we can do the initial management and transfer it to Ankara, where we have the angio, the neurosurgery, and all the facilities. So this is a brief introduction about the hospital. Now, if you look at emergency medicine as a specialty, I just want you to give you a brief thing about it. It's basically a very simple thing. We are speaking about a specialty where you diagnose. At least we try to diagnose most of the time, but sometimes not necessarily we diagnose a disease. We do a provisional diagnosis, right? If you have a patient with epigastric pain, we are not sure. It could be anything regarding the abdomen, anything regarding the chest. It could be acute coronary syndrome, many things. But we go for a provisional diagnosis. But the important thing is to deliver immediate care and to initiate the proper treatment. And one of the most important things that we are speaking about, not all the presentations to the emergency medicine are critical patients. We have approximately probably just 10% of all the patients all over the world that they come to the emergency department are critical or Cat 1. But we are speaking about the art is basically to point these patients out of this big pool and give them the proper treatment, because some of these diseases that we know are time-sensitive situations, whether chest pain with the aortic dissection, some strokes, of course, traumas, and many other things, sepsis. So this is the role of emergency medicine. And one last role, which is not written here, it's important that we must know also our limits. We are not there alone. So this is like it's a puzzle. We are there to see the patient, give the initial treatment, try to diagnose, go do the provisional diagnosis, and I have to know my limits. I want to know when do I need the cardiothoracic surgeon. So in case of suspected aortic dissection, probably I would give a call. I'm leaving now to the CT scan. High chance that they got the aortic dissection. While in the CT, then we can make the phone calls and we have to rush with the patient, whatever needed. So this is basically, this is what's emergency medicine about. And also one more thing that I want you to understand, or at least I want to touch it, you probably know it as well, that what is triage, right? Like you hear emergency medicine is everything about triage in the pre-hospital, in the hospital. Triage is basically, we are speaking about a preliminary assessment of the patient to decide their urgency, how urgent, what I should do now, what are the resources that I need, and what are the treatment and the nature of treatment that is needed. Okay, so we are speaking about a concept that came from Napoleon's chief surgeon back in the days, and they were basically just need to decide, is this patient need to be transferred? I can treat the patient now, or basically they are I cannot transfer, and we cannot give further treatment. In my institute, there are many triage scores, many things could be done. We use the ESI, Emergency Severity Index. We are basically speaking about, ESI score from 1 to 5. So 1 is very severe patient that they come with ongoing CPR, major trauma. So these patients need critically now, if we don't do intervention now, these patients are in risk to die immediately, or these patients that they come with a small wound in their finger and they don't need many resources, and everything in between, in the middle. Most of our patients, basically, they come in the emergency department with a ESI severity index score of 3. In my opinion, and what I think what we should teach, or what I try to put in my department most of the time, this is a nice score for categorizing patients. It's good for the Ministry of Health to see what are the patients that they are coming. But for us as emergency doctors, emergency departments, the most important thing, we should always see, is this patient critical and need immediate treatment now or not? This is the thing that we should always, because chest pain, again, they come, their vitals are fine. But what if they have something that is crucial that I don't know, critical, and it will take me 2-3 hours? So here, sometimes we miss things. This is something that we need to speak about. So for many years, emergency medicine departments all over the world, I would say, especially in Israel, it have been the doctors that were working inside this department. They were specialists, not in emergency medicine. They could be surgeons, mainly internal medicine doctors. They finished their specialty in internal medicine, and they found themselves somehow working in the emergency department, triaging patient, surgical, non-surgical, internal medicine, etc., etc. This model, it's still ongoing. It's not evolution that have been happening now recently. But what happened is, if you wish to be a subspecialist in emergency medicine, you could go from any specialty that you have done through your medical career, and then do a training of 2.5 years in order to be a subspecialist in emergency medicine. This was started in 2002. But in 2010, the specialty of emergency medicine have been approved in Israel. If you wish to be emergency physician, you can do your medical school, 1 year of internship in Israel, and then choose from day 0 that I want to be an emergency physician, and do the specialty, which is 4.5 years. In the world, in the States, it's, for example, for 3.5 years. In Australia, it's 6 years. So it depends. In Israel, it's 4.5 years. And in 2011, we were 4 doctors enrolled in this emergency medicine program as specialty. For the sake of this presentation, I spoke with the president of the Israel Society of Emergency Medicine, and I got this number now. Today, we have more than 300 residents, active residents, all over Israel doing emergency medicine. 90% of them are doing it in the direct route from the direct residency. So they are not specialists. They just started to do from day 0. And the curriculum is basically doing many months, 30 months in emergency department, some in internal medicine, intensive care, of course, trauma, pediatrics, and 6 months of research. One of the good thing happened. I'm not sure if it's accidental or planned. One of our good friends for the Israel Society of Emergency Medicine, and his name is Professor George Breitberg from Melbourne, from Australia. He was my mentor when I did my fellowship. He visited us frequently in Israel, and he said, you know, if you compare Israel to Australia, it's a small country, and you are doing something nice. It's a new specialty in emergency medicine. Why don't you just and you know, emergency medicine everywhere, by the way, it's a international phenomena, that it's not homogeneous. Not everyone, they do the same, even in Israel. And then he's like, but at least the theory part, it have to be standardized for everyone. So what we did, we built up, it's a 7 or 8 years already running program, that we choose one hospital inside in mid-Israel, basically in the geographic area. It's usually next to Tel Aviv. And what we do, we bring all the residents from the emergency medicine residents at one place for a simulation center to do a training. It's a syllabus. It was for 2 years, then we did it for 1 year. And we just cover main topics that we want every emergency medicine resident to be familiar with. We don't want anyone to reach an exam because they have been coming from a small hospital, North Israel, which is non-tertiary, and they don't know how to manage airway, or they never have done catheter ICC for pleural effusion or trauma. So we said, at least let the theory part, this is our responsibility, let's do it. And we were lucky to have, due to the geographic area, we have this program have been running now really for more than 7 or 8 years. One of the facts about emergency medicine, this is also part of the introduction. So we are speaking about a specialty that it will always be an integral part of the healthcare. You cannot take it out. One of the best examples probably you could look in 2020 with the COVID. Patients had to come face emergency medicine departments. Disaster medicine, it's just going more and more. Global warming, earthquakes. You see, even if you will do a really good pre-hospital preventive personalized medicine, these departments will always be there. And one of the phenomena also in Europe and all over the world, that, you know, there is not much increased numbers of beds in the hospitals compared to the population. So there is decreased relatively numbers of patients bed to patients presentations to emergency departments. And we are probably, and one of the unique thing about emergency medicine as a concept as well, we are speaking about this is the emergency department, right? So everything, the input to the emergency department, it's basically, it's not something that we can control. The door is open, anyone can come to the emergency department. So this is one of the challenges in emergency medicine, right? Mass casualty happens, then all of a sudden we have to prepare ourselves to be ready to accept X 100 or less more of patients immediately. But meanwhile, we are treating someone. But also the output, it's something that we control, relatively control, right? I can probably do discharge patients a little bit quicker than it should be, but still I cannot control all the discharge. When you admit patients, it's also a global, unless you are a private hospital, it's a global health problem. There is access blocked from the department. You admit the patient, you decide to admit the patient, you come sometimes next morning and they are still there. So how exactly you control? And with all this chaos, patients still coming, increase in number in the presentations to the ED, emergency department, and still you need to control all of this. So this is a big challenge. So this is basically the entrance of my emergency medicine department. As you see, this area here, it's a ground floor. It could be used in case of a mass casualty, in case there is a major event that we need to do triage outside the emergency department. We can evacuate immediately this place. We can also put some tents in case of some biological hazard or chemical hazard, a big truck that was had a crash and it has ammonia, or there was explosion at some place where they have some ammonia, and we know probably we're gonna get 10, 15, 20 patients with they are contaminated. So we can use this area as well for the contamination. And if you look at the just a small map to have something in proportion, I'm talking about we have 63 rooms. All these 63 rooms are fully monitored. Probably the COVID, the only good thing that brought to our emergency department that we monitored all the beds. So half of the beds that they were not monitored, we had the equipment, and we have adult. So it's divided to adult and pediatric area. We have the trauma. It's just in the middle of the room, so patients walk immediately straight forward to the trauma. We have 27 beds extra monitored, and one more thing, we have the fast track, which is the ambulatory care. I do have an observation unit. It's a 12 beds observation unit, and the goal of this observation unit is basically to do a high turnover for patient safety and for our safety as well. So those patients that they just cannot really go home, that they don't need the admission, or probably they need 24-hour assessment, antibiotics, chest pain, low probability chest pain, so low probability of any disease. We admit them at this observation unit. We have about 5,000 admissions every year, and patients need to be ambulating because we have only one nurse for this 12 beds, ambulating, and exclude psychiatric disease, exclude patients with contaminated or they have any infected disease. So this is how the observation units work. And we have also an imaging, which is in the same floor in the emergency department. This imaging including one CT scan only for emergency medicine patients. And we do have 2 X-ray rooms and 1 ultrasound room. If you are thinking of building probably a new emergency medicine department, or the view for the future vision, I think the big emergency departments, they probably need 2 CT scans. Today, CT have been one of the main diagnostic things that we use in emergency department, because it's not operator dependent, it's available, and it gives us, we use it more frequent. So today we don't do X-rays for C-spine injuries, for example, because any suspected really C-spine injury, we need to do a CT scan. Any infection in the abdomen, chest, usually everyone asking for CT scan, which I think it's a good approach, yeah? So the number of the CTs that we order is just going up and up. This is one of the access block in the hospital today. The head of the division for radiology, he's not happy with this, but I mean, this is not exactly my problem, but we chase for patients' health, but this is something that we should probably speak about. And one more thing, in the next year, we are going to have a new area with another 15 beds. All of them are monitored, and the vision view for the next 5 years is just building another 1 floor identical to this floor, where the observation unit will be expanded to from 12 to 25 beds for another floor. So this area would be used for our ED. Pediatrics will be moved, but the rest will be just expanding the ambulatory area. One of the things in Israel, I'm not sure if you do it in Brazil, if it's a standard here from Ministry of Health. One of the things, due to the sensitive of the place in the Middle East and wars and hazards that we face, basically our department, when you build it, it's from day 0. You need to build it in a protected area. So, you know, if there is any alarm in the country, we don't need to leave the department from here outside. So you don't have to walk to look for the protected area. With all the emergency medicine department, the observation unit is not, and the ambulatory care is not, but the main patients inside with all the monitors, this is a protected area. for chemical, biological hazards. It's designed to be like that. Just had a few pictures. This is the main area that we use. We will later you will have a photo, a picture about the trauma. This is our observation unit, and this is one of the. I have 3 or 4 procedure rooms. This is a stitching room or procedure room that exists in the walking area. One more thing, if we look at the staffing, so we have 77 nurses. One of the things that happened in the last 6-7 years, that due to the shortage of doctors, due to the need, due to the increase in the presentations for the emergency department, together with the Ministry of Health, we allowed paramedics they built a physician assistant to be a physician assistant inside the emergency department. So they had to do 2 years a course in emergency medicine, and they give them good qualification to work in the emergency department. Today, I have a trained paramedics and double boarded with physician assistant. I have 4 of them. In the last 1 year, less than 1 year, probably 9 months, I added 2 phlebotomists. They just take bloods. Usually they are medical or nursery students. This is basically to help patient flow, because you are walking in the walking area. Patients need to get some medications. Even if you have the doctor seeing the patient and then nurse to give some medications, then the next patient come in, they need to take some bloods. The nurses in my institute usually take the first drawing bloods, but then it was also access block. So all the time we need to chase to see where I can fasten this pathway. So it's something that, and by the way, it's not, of course, it's cost effective, yeah. And I have added 2 phlebotomists, 2 in every shift to do ECG. We have a medical students, 6 medical students, of course, the rest of the staff, secretary, administration, office. And one of the things that I am introducing now is paramedics without the course from the Ministry of Health. So I have 1 paramedic now working in the department. As a director, as a hospital regulation, I can basically, I can build for him or her what they are allowed to do in a regulation for things that they are allowed to do. So it's something relatively brand new. There is 1 hospital in Israel that they have already paramedics, and we are the second one to have a paramedic. And I believe this is a workforce that must be integral in the emergency department, and it's very important. Now, regarding doctors, we had in 2010 about 8 senior doctors. All of them are specialists, but not in emergency department. We had only 3 specialists in emergency department, and we had 1 resident that completed a subspecialty. She was an internal medicine doctor, and she completed a subspecialty in emergency department. And now, today, I have 8 doctors that all of them are boarded in emergency medicine. They are senior doctors boarded. I have today 12 residents in different levels. So 3 of them are in the first or second year, 3 in the middle, and the rest, they are just up after exams and up to finish their residency. One of the things that is also new, I totally believe that if you want to have a good place, a good emergency medicine department that it's heterogeneous with a patient, I think that the staff need to also be mixed. And I did my fellow in Melbourne. So you always have the chance, if you have the chance to train, or at least to see what others are doing, to bring it back, it's always have a good benefits. So I believe in that. So we had the opportunity in June, we have our international fellow. She comes from Chile. She started working at my department. She will be for a 2 years training program, fellowship in resuscitation. And next month, in September 1st, I have 1 doctor coming from Palestinian authority, and he will start also doing that. And I am going to expand this. So I think as a center of emergency medicine with some capabilities, need to have international trainings and messengers and do this collaborations with different institutes. So one more thing that is important in emergency department. I'm showing this slide because this is what happened in every institute all over the world. There is probably you can edit it a little bit with one slide, one box, right or left. But basically, the patients, they enter the office, they enter the emergency department, then need to go through the admission office. Then there is a triage nurse. Some institutes in the world, they have a doctor as well, but usually it's a nurse, 80% of the hospitals worldwide. Then there is a doctor need to come, evaluate the patient. Usually it's a short period of evaluation, from 5 to 10 minutes most of the time. I'm not speaking about trauma, major trauma, but this is 65% of the patients that they come to the ED. And then we have to send some labs, some imaging. The patient need to wait. We have to wait for the results. We have to wait for the re-evaluation again for the doctor. And basically, if you look at the patient flow in the department, the patient, they come, they will do this whole process most of the time from the 5, 6, 7 hours that they come in the ED before they discharge or they admit, they are waiting. So I'm putting this slide because if you, anyone in the audience, us, can have any startup thinking outside the box, or probably put the clinical pathways that they can accelerate the patient flow at any stage here, you are winning. So this is where all a lot of effort is being put now in order to accelerate a patient's flow. And what are our challenges? So this is, I give you a brief view about the specialty, the department, etc. But we have many challenges as well, specifically probably for the ED. So we want it, or whether we want or not, there is increased number of presentations to the emergency departments worldwide, in Israel definitely, and in my ED, we saw last year almost 100,000 patients. This is without deliveries and pregnancies. 100,000 patients come to the ED last year. Our admission rate is 35%. And this year, from the beginning of this year, there have been increased by 10% compared to last year. So this is a phenomena that have been going on and on. To 2020, of course, this is the COVID. So I think we shouldn't really point that. But you look at the trend that basically there is increase in ED visits. And one more challenge is basically the modern medicine that we see today. Patients with many diseases, mainly cancer, that they are diagnosed, they got treated, and they live good life for many years. So this modern medicine, together with an institute that, you know, it's a prestigious and patients want to come there. And one thing that it's a big challenge for healthcare system today is people, they live longer. So today in every shift, we have patients, geriatric patients, come to the ED after a fall from a bicycle for a trauma of 70, 75 years old. So this is a different entity. We still need to do the CT scan. It's a different approach for geriatric trauma or geriatric injury, but this is something that if you don't speak about, this is something that's happening. A lot of our patients today, they are really, many of them are, you could see the difference 10 years ago and today that you walk on the department, that you see patients are independent and they come to the ED and many of them are there. So this is also a challenge. If you look at the rush hours in the emergency department, most of our patients, basically the trend, they come by the morning. So this is between 9, 10 o'clock. Patients present to the emergency departments. The peak of the presentation is around 1 o'clock. But these patients that they come here, due to the fact that there is many of them came at once, and we still with the same resources, so they wait longer for the blood, wait longer for the triage, wait longer for the physician to assist them, right? And if you look, this is our Sunday, this is your Monday, basically. Sundays, this is our busiest day. And this is the graph where I could probably have a look from my BI, a dashboard. I can have a look, and probably I will show you. I'm trying to edit my stuff according to the presentations to the emergency department. So this is mainly what I want to point here. And if you look at the patient categorization, as I mentioned, so probably 50% of the patients that they come to the ED, they don't really need to come to the ED. This is what happened with the COVID. Everyone was scared. They didn't come to the emergency department. The patients that we saw, they were really sick. We had to treat them. So 10%, about 10 to 15%, they could be critical. And our role is basically, this is, as I mentioned from the beginning of in the introduction, our role is basically to point, to take out from this big pool, these patients that they are sick and we need to treat them. This is a challenge. Now, if you look at the, in 2021, it's only 2 years ago, one of the main things that happening, or it bothers, or I don't know, it just happened there, that if I just went, I looked, what are, from out of this 100% patients that they come to the ED now, what are the percentage of the patients that the emergency doctors saw them as a first exam? The doctors saw them first time. So only 28.2%, or let's say 30% of the patients, they have been seen, examined by emergency medicine doctor. If you look for 2021, it makes sense. Why? Because you know the doctors work our work, most the emergency medicine. Most of us, they would come 8 o'clock in the morning to work. 4 o'clock in the afternoon, we want to go home. So this is the third of the day of the 24 hour, which makes sense. That's why we see only 30% of the patients. Okay, but there is multiple problems with this thing, because these patients that they come here at 4 o'clock, the nurses at 3 o'clock, they want to go home. Their shift is from 7 to 3. Is it similar here in Brazil? So 7 to 3. Then the nurse that at 2:30, they usually want to do the handover. Patients come at 2:30. Only by probably after 1 hour, he could be properly seen. So there is a big gap here, and I didn't really like it. I'm not inventing anything new. I'm just, it's something that really bothered very much. And then I looked at the graph, the entrances, and I said probably there is something need to be done for this patient's flow. So I introduced basically something called swing shifts. So basically bringing people at 12 o'clock at noon. I'm speaking about doctor's shifts mainly now, and leave at 8 o'clock p.m. So they stay there wherever you have a more patient flow, we have more staff is there. So I don't want most of my doctors 8 o'clock in the morning sitting at the walking area from 8 to 10, having 3 times coffee, but multiply it by 3 times, and there is no patient. So this is the graph. This is basically what it's saying. So this one thing have been introduced in the last 11 months. And one more thing, I had only one doctor at evening at the walking area, a senior doctor, and this doctor was an internal medicine mainly. And usually they didn't really want to come to the ED. So, they were coming from, they are excellent, really excellent. They are my friends, they are good colleagues, everything is fine. But if the patient have a pneumonia, they will do the best for them. If they have pneumonia, but he just fall from 30 centimeters and hit his head, and he need a CT scan, then he need to wait for the neurosurgeon. So this is what's all about. And what I did basically, I replaced the first tour, the first graph that I had with the for the evening, for the working area, all of it by emergency medicine doctors. The second thing, we increased. It's of course it costs money for the hospital, but I had today 3 all the time, every evening until 11 o'clock at the evening. I have 3 emergency medicine doctors trained in the department until 11 o'clock, and their goal is, of course, see the patients, make sure they are okay. The time to first exam, it must be shortened. Time to discharge must be shortened, and of course, to hunt these patients as much as possible, not to miss these critical things. It's not easy, but it's something that need to be done. And on Sundays and Thursdays, according to the graph where I have more and more presentations, I added only there another doctor. So this is what happened in the last 1 year. And if you look at my within 1 year, I have increased the number from 30% for 2 years to 45% today are examined by emergency medicine doctor. I'm not saying that. What I'm trying to say is I said it also from the beginning. Some of the doctors, they have to be integral part of the emergency department. I'm not saying that emergency doctors need to see everyone, but most of the patients, 80% of them, I need to chase this number to increase it to 80%. Still, I want a neurologist to see a stroke, acute stroke that need to be, I have to chase some time, probably do a TPA or take the patient for the brain cath. I want them in my emergency department. I don't want to deal with that. I want also the psychiatry patients that they come with acute psychosis. After I do the evaluation as emergency medicine, they need to see a psychiatrist. They need to be integral part of the emergency department, as well as probably one orthopedics and trauma fellow that need to be there, because if the trauma need surgery, they have to make these decisions. But the rest, 80% of the patient, this is the number that I'm basically chasing. One more thing that also I believe in it very much is the concept of fast tracks. Fast track for trauma at my institute have been there many years. So any pre-hospital ambulance or paramedics, they have a hotline in the department, and they call and they ask for trauma. This will go to our navigator center or the secretary sitting inside the emergency department. They will activate a trauma call. Activating trauma call, it means they will call the surgeon, emergency physician, radiologist, CT scan to wait for the patient, operating theater if needed, of course, blood bank. So we have a protocol for trauma. I'm sure you have something similar. We have 2 helipads. Basically, one of them in the roof, and the other one on the ground, because our military big choppers, they are not allowed to land on the roof. But we have 6 beds of trauma that, as you see, they are really big beds. I would say really it's a state of the art, and all the facilities need to be done in trauma. They are whether thoracotomy or RIBOA or surgical airway, anything that need to be done could be done at this beds. One of the other things that have been recently introduced in the last year is the concept of fast track for chest pain, because these rush hours, it's like a bomb ticking. Bomb ticking, patients are outside in the walking area with some chest pain or epigastric pain, and it just, I can't really sleep at home, and I know something like this could be happening. Of course, I'm not avoiding 100% of this, but most of the things could be avoided like that. So what we did, it's in the walking area, one of the beds, we turn it to ECG bed, and if the patient present to the admission office and he or she, they say above age 40, they have any chest pain, any epigastric pain, any shortness of breath, they will give them, they flag the file with a red sticker. It's written on it an ECG, and they will bypass the whole queue and go immediately to this bed. Emergency doctor / a senior doctor will come to the patient immediately with a nurse. They will do bedside evaluation, and he will decide they can stay here. The ECG is fine. There is no ST elevation MI, or it's a high risk. They need a monitored bed. This is where they should go. This is something that it's working and it's nice. Of course, as mentioned, this is a patient from last week, 75 years old. He came by his own. He didn't take an ambulance. Came to the admission office. He said, "I have chest pain radiating to the back." It was 4 o'clock in the morning. Straightforward to the ECG bed. His ECG was fine, but still it was a little bit of risk, age, etc. And he had an aortic dissection from door to operating theater. It was probably nearly for 1 hour. Within 1 hour, he was in the operating theater. The one more thing that also have been introduced recently, it's the fast track for stroke, and it's one bed that it's empty, like the trauma. Although sometimes we are itching because some of the patients are in the corridors. We have a high flow, and this bed and the trauma are empty. But this is how it works. Since March, we have seen here more than 100 patients. The 100 patients, all of them done the CT scan below 20 minutes. So this is basically not calling the neurologist. We have a 70-year-old lady with a suspected stroke. But why? What happened? She woke up with some slurred speech. Did she wake up with a slurred speech, or the slurred speech started after she woke up? No, it's not something that we could also leave it like this in this way. So basically, this is a simple, primitive protocol. It says if anyone in the department, anyone in the admission office that they don't have any medical background, anyone from the pre-hospital, they will call the hotline and they say we have suspected stroke. That's it. This is the keyword. They will go straight to bed 29. Inside we have bloods already. The tubes are waiting for the patient. We have coded which bloods are needed, plus minus if they are in anticoagulants, if they need the anticoagulation profile with the levels of apixaban, etc. And then we had the intercom for the lab to tell them there is urgent labs need to be done are coming. CT is waiting for the patient, and of course, neurologists and emergency doctors and the nurse, they are next to the patient to decide what they are doing. CT scan quickly, and then yes or no TPA, yes or no brain cath, and this patient need to go outside this bed. So this is basically the simple concept. This is CT perfusion that have been used probably for the last 2.5 years. It's something also relatively new. One more thing that haven't done yet, but this is my next fast track. It would be patients with sepsis. Sepsis, as you know, high mortality. There is evidence that patients with sepsis, their mortality is probably 2 or 3 times more than trauma. You see what happened when there is a trauma patient come to the ED. We even saw it yesterday in Sao Paulo. You have more staff treating this one trauma and multiple staff, and all the ED stands alone waiting for this trauma. But the same hour, probably 2 sepsis patients, they come in, and they usually, unless you are very aware of that, they don't get the proper treatment usually. So we know about sepsis and the illegal directed therapy, giving this fluids, etc. for the next hour. So this is hopefully within the next few months will be my next fast track. One more thing that also it's in the patient's flow, department flow, is basically I'm trying to make, with respect to all my colleagues that we work really together, I'm trying to make my physicians more and more independent. Meaning, if I have a patient today that need one of my doctors, he's a senior emergency physician and he's doing subspecialty in pain management. So most of the patients that they come to the ED now with that they needed some blocks or any alternation above standard of pain medications. So I have someone, a reference for that. We have, I divided the staff. Some are responsible and for medical simulations, risk management, toxicology. One of my senior doctors next year is traveling to Melbourne for half a year of fellowship in toxicology. Of course, research, as in probably worldwide phenomena, in Israel definitely, in emergency medicine, research have been always not developed. It's something that I put a huge effort in the last year on research. We got a very nice, so I have one of my doctors that he's centralizing, or he's the head of the research and academy inside the department. And together, within the last few months, we got a nice grant from the hospital, and we are now recruiting a physician assistant in order to promote the research, because of course we all know the importance of research in the field. And of course, ultrasound is something that have been fancy. Most of us in the department now do ultrasound, and we are there. I have probably 5 ultrasound machines in the emergency department. In every session unit you enter, you have an ultrasound. Of course, with all of this mess, one more challenge is basically we still need to. I need to make sure that my staff have a well-being. We have to be aware, of course, of the environmental emergencies, patient safety. It's paramount with all of this mess that we have. I spoke about so far. Mass casualty is something that is happening, and of course, the challenge is basically one of the other challenges that are here is I need to keep state-of-the-art education and residency. I'm not the only institute in Israel having residents, right? So probably 20 kilometers away from me, there is another hospital that they have also emergency medicine department. And you know, it's without this competition in medicine, we cannot. I'm not going to say we cannot survive, but it's something that give us the trigger, of course, to keep state-of-the-art education. One more thing that have been also edited or upgraded in the last year. So it's in Hebrew. You don't have to read it. It's basically I built an academic program for the department every day for the whole year, 5 days a week, 9 o'clock in the morning. We have 1 hour education for the department. It's including twice medical simulations with equipment. So some days we start warm up with megacode, some CPR, and then we have 1 hour teaching for the interns. But the rest of the week, it's basically doing some simulation, ultrasounds, exam preparations, radiology session once a month, and it's very important quality improvement. So once it was called morbidity mortality, we used to call it. One of my senior colleagues, he insists to call it quality improvement. He's American, you know. So it's something that new. We don't do everything, of course, perfect. It's egoistic to say that. We also do mistakes. We bring always open access for every doctor and nurse in the department. Whatever they feel, they know something could be done better. They have to bring. They have access to bring it, and we discuss it in a formal way in a meetings in the department. And we have also added it's something. I don't know, it could be cosmetics also, that we present a case that we have done also something good. So what are the things that could be kept? If we saw aortic dissection quickly and we done things that should be done, then we can put it there as well. So medical simulation is something that I believe in it very much. Most of it, it's medical scenarios, but of course you all understand the importance of communication. We have a lot of junior doctors from other departments come to our department doing some night shifts. Usually they have no clue about the department at all. So I try to bring them all together to do sessions of simulations together with the nurses. This is my physician, one of my physician assistant. We have been doing ultrasound workshop for the last 2 years, just increasing in the demand. 80% of our hospital and RN campus nurses have done ultrasound workshop beside the FAST and the EFAST that we do as doctors. They have done IV peripheral access. It's something that we introduced it in the emergency department. Of course, airway workshops. And one of the important things, we have done now a peripheral nerve block. It's something that also have been pioneered probably in the department, just to make the department a pain-free department. We have doing it twice a year. We do such a course. Going back to the introduction, so we are part of the academy for the Hebrew University. We teach second, fifth, sixth medical students. We are pioneers of a BLS course for all the medical students in the university. So just at the first week of their second year, where they start to learn the physiology and etc., we do for them a 2 days concentrated course for all for about 180 students every year. And the first, the Israeli Association of Emergency Medicine, the course that we do, we are part of this program. We teach there. We host 2 or 3 days out of this days that they have, and of course, some of my doctors, they are examiners at the board for their exams. I'm just giving you. This is one of the conclusion course of 2 weeks course for fifth year medical student that they come. We do for them as a competition in the trauma. So we have like 5 stations, and it's something that a little bit soft in the environment inside the department as well. We have been involved in multiple publications and showing that. I'm proud of this, but it's not enough. I think we have the capacity to do it much more and more. One of the important things coming here and present here as well, we can open also opportunities for collaborations in research as well, which is also something could be easy as well. Sedation, ultrasound, I spoke. We are really, most of my doctors today, they do ultrasound focus. There is no chest pain come to the ED. They don't take the probe and look at the heart. They don't look at the valves. Not something that I want to know, but I don't want to know that an oncology patient coming with weakness after chemotherapy, if they have a tamponade or not. This is atypical presentation. So they don't come usually with typical things. So we look at the heart, we look at the lungs, pleural taps. We do all the centralized with ultrasound, sedation. Every single shift, the orthopedics, the surgeons would come ask for sedation in the department for any procedure. It's something that have been widely increased in use in the last year. And of course, nerve block. We have done every single patient come today to the ED with a fractured hip. We do a fascioiliac nerve block or ultrasound guided block. Now we are expanding for rib fractures. This is the 2 things that we are really, I would say, not only pioneering, but also it's demanding, because these patients, we give them less opioids. They go more comfortable to the operating theaters. The orthopedics like it as well. The patients, they less bother because they are in less pain. And all the consequences of giving these patients less and less opioids. This is 2 pictures from the COVID that we had. One of the things also I want to touch here in this presentation, I want to use the opportunity to speak about a little bit just mass casualty. So mass casualty, if you think about it, it's not necessarily need to be something really big, really huge to happen outside. Because if you have, it's basically, we are speaking about this proportion between the number of the casualties, the patient that they come, and the immediate available survival resources. This is the definition of mass casualty. So if we have any number of patients, it could be 5, it could be 15, it could be 200, any numbers of patients that they enter now to one place that we need to treat, and we have a shortage of any personnel and equipment, this will turn the scene into mass casualty. This is the definition of mass casualty. And of course, there is natural disasters, technical, it have been increasing more and more recently. This is something that happened in Tel Aviv. I don't think ever we had a flood in Tel Aviv. It happened 2 years ago. This is fires every second year. We have a big fire somewhere, and patients come to us as well. This is something that happened. It's a technical hazard, basically some collapsing thing. This event, this is in the synagogue. You know, in this event, more than 200 injured patients was in this, and it happened in North Israel next to a hospital, which is non-tertiary medical center, and you can understand the mass casualty and the event, the massive event that happened there. And of course, we are in an area with a little bit of threat from war, from terrorism, bombings, and etc. And one of the things that we do is basically doing drills, not only waiting every time for the event to happen, or the casualty to happen. We do a lot of drills together with the fire department, police department, the EMS hospitals. And one of the main rules that we basically do is usually we have one of our chief surgeons outside the department doing the triage, and we divided the emergency medicine department, the map that I showed you at the beginning. Every unit there is one in charge, one physician in charge, one nurse in charge, and the patients. The most important, there is few elements are important in mass casualty. Patients come in, they go. We have the one way, the one pathway rule. It means if the patient comes to the trauma, they leave to the CT. After the CT scan, they have to go either to a recovery room or intensive care room, or they go to the operating theater. So they don't come back to the trauma. The same for the cubicles, and the same for the walking patients. Even if they come for an X-ray, we have most of these casualties, by the way, they are orthopedics. If they don't need the surgery, they will need a surgery within 24 hours. So they will go to the Röntgen, do the X-rays, and usually send them upstairs, or upstairs mainly, where we decide according to the numbers of the event. They will put the cast on, and they are not discharged, even if they are well. So we have a discharge area. This is something new in the last year. In the drill that we did in December, we had an area of this for discharge, because every patient that is discharged, they need a secondary look or a tertiary look. They make sure that they are good, they are safe, they can go home safely. And the most important thing, every patient like this, they will have a social evaluation, make sure that they are okay and they can go home. Or alternatively, we always open information center, always from zero time for the families, because in such events sometimes they want to call to know what happened, where are their injured or suspected injured son or daughter or relative, and these events usually they are a magnet for the media. So it's very important with the security. Make sure that any media that they come close, we usually give them an area outside the hospital. Usually it's in the emergency department parking outside, to concentrate most of them there. And when you want to give a message or relieve a message to the press, you should go to them. It's not the opposite, because they will do a big mess. One of the things that also have been unique, I would say, to Hadassah, to our emergency department, and to Hadassah International, with the help of Hadassah International and the initiation from Jorge, is basically initiating a clinic at the Polish-Ukrainian border last year for 3 months, and we had delegations from the hospital. We had basically a clinic next to the border that we had our staff from the hospital, doctors, nurses, gynecologists, psychiatrists. You know, it was multiple teams that traveled there, and we basically had this a clinic for 3 or 3.5 months, and every shift we saw more than 100 patients. And patients, they are basically refugees or immigrants that they just left the war, and they found themselves in a shopping mall, and this is where we had our clinic. So I will, in the last probably 10 minutes, I will give you the second talk of the presentation. So you can imagine the department, patient flow, challenges, critical diseases, mass casualties, all the things that I have said, and you find yourself, and you don't control the input, you don't control the output, and you find yourself in a place where more or less you still want to control this chaos, right? So what are the means that we probably, beside the things that the human beings that I said, probably they can help us, and they can give us a little bit a view to the future. So, you know, today, all the technology and every presentation or everywhere you enter the social media, you even the all the magazines, the medical magazines is speaking about the AI. So if you are a little bit technophobic, it's the time to become a technophilic, because this is the more or less where the world is going, and how basically these things can help us. So the dashboard that I showed you before, it was released only last week for me. So it's all this big data can be used basically for data analysis, to mainly to look for retrospective things, having a dashboard online to see what are the who are the patients that they are coming, when they are coming, how many of them have been admitted. This is something, of course, that could be relatively easily done today. This is the help of the BI. And one of my goals and one of my immediate or recent things that I'm trying basically to do is not to turn the ED into a smart ED, but we need to use to know at least where to use the technology in this big mess in order to help us. And we are trying now to develop, we are nearly there, is basically when the patient comes to the initiation from the pre-hospital, we take all these data from the paramedics, from the ambulance, and I want to know when they arrive, who is the patient that is coming with them. And the next step is basically take these vital signs and put it in an algorithm where they can help us making some decision, then help with the triage. And I'm not saying that it's going to replace the doctors or the nurse. I totally believe that there is no AI or technology going to replace the clinical decision of a physician standing in front of a patient. But of course, it will ease, or at least give us a percentage. What is the probability that this patient is going to be admitted? Then the workflow for us is going to be a little bit changed. So all the data, I want a better communication from the pre-hospital. This is something could be done. A better communication between the pre-hospital and the hospital. When I say pre-hospital, today we are in the phase that we can take things from the ambulances. One of the biggest ambulances company in Israel, it's called MADA. It's easier, and we are managed to do that. But also we have a lot of community physicians that that refer the patients to our ED, and they know from the beginning that they want to transfer it to Hadassah in Karim or to X to Y to Z. This is the next step where it also could be there. So we are speaking about clinical decision support system. This is where AI basically could help us inside. And one of the things also have been relatively new and evolutionary in medicine is basically using the virtual reality. In Israel, I know that it started mainly in the military for patients, for soldiers that they have developed some psychiatric slash anxiety. So they have been using visual reality for therapy actually, but this thing mixed reality and virtual reality have been now more and more being involved in in rehab, in perioperative planning, patient education, and medical simulation. And of course, all the digital world today, you know, we have many patients. You know, usually we used to put patients for the observation unit for 2 days, just if they had one episode of syncope, and wait until they have their next cardiac arrhythmia, which never happened. But today we know that we have multiple smartphones that they could detect arrhythmias, glucose monitoring, which could be also sent to one center where they can concentrate the data. And one of the main things that now have been very well established and developed is basically in the emergent radiology. IDOC, are you familiar with IDOC? I'm not their representatives, but this is something that have been introduced in our tax system. It's an Israeli startup, by the way. And IDOC, they built a AI protocol, which is simple. It took them a few years. They cost, they are making a good fortune of money, but the idea is simple. They could, when you send the patient to a CT scan, they could immediately, once the patient, before they come, they just get out the scanner. The AI can tell me as a physician, treating physician, if they have any intracranial bleed, intracranial pathology, rib fractures, pulmonary embolism, bowel perforation. Okay, this have been now approved, used. It doesn't replace the radiologist, but if it says that there is pulmonary embolism, you need to have multiple radiologists to approve that there is not. Yeah, so this is how it works. And September 1st, in 2 weeks or 10 days, the same system now from IDOC is going to started at my institute at Hadassah with fractures. Okay, the future, I guess, because I was in the meeting when we tried to plan the whole thing. The future would be, I don't know, this fracture is stage X. It's gonna diagnose and give you probably a treatment plan, which kind of cast you need to put, and then discharge the patient, or this patient need admitted, for example. Or the orthopedic surgeon, when the IDOC came to introduce this application, they were asking, I want to know with the AI, I need their help to tell me what I should do in the surgery. I'm like, so you know, there is definitely no limit where you can demand things, but this is something, it's working, and it's there. And one of the things also we have been developing now, it's not our invention. It's not something that I came with, but it's something that exists in Israel in one of our hospitals. Is basically a self check-in for desk. You know, you come today to emergency medicine department walking, and then you can basically press that you came with a disease or a complaint, or is it uh, accident, or what are the, and from there, if you know that it's 40 years old and chest pain, then machine will tell you, no, you shouldn't be here, you should go inside. But the vast majority, 20-25%, still could bypass the admission office and go inside the department and do the self check-in. Telemedicine have been now widely used worldwide. COVID have, expand the use of this telemedicine. The numbers of emergency medicine department visits, this big challenge that putting the emergency medicine departments today will leave no space unless you put a corner for telemedicine in emergency department in the next few years and giving some communication to the public, because otherwise we won't be able to treat them with this trend now coming to the ED. Last thing, whether, I'm not sure if it's better or worse. It's something that it's happening. We should not only cope with it, we should probably think how we could bring these applications, technologies, and bring them to us to help us. If the future also, if you want, if my at least my goal as well is basically leave a place for all my emergency doctors having some subspecialties in different fields. So this is how also making the department more and more attractive. If you think of building ED, well, this is what we are doing now, a little bit upgrading the department. You should think of having a telemedicine probably corner or room, a VR room, and definitely beside the research area that today a lot of places they have a lot of departments. This is something that also need to be there. Thank you. Questions?
Eu vou colocar o isso aqui, e aí. This way you can answer the questions, yes?
Okay. Nobody translated, no?
She's a gente tem muito microfone?
I have a mic here, no? Maybe I come down, no?
Bom dia, doutor. Meu nome é Josué, eu sou médico da cirurgia geral aqui do hospital. E eu gostaria de entender um pouco melhor sobre como funciona a participação das especialidades cirúrgicas dentro do departamento. Eu não consigo perceber exatamente qual o nível de participação na hora da indicação cirúrgica, na hora da decisão sobre o passo seguinte após a estabilização do paciente. Como elas participam, a cirurgia vascular, o paciente da cirurgia geral, especialmente nos casos que existem decisões com múltiplas vítimas. Como se dá essa participação dos colegas especialistas nessa área? Uma segunda pergunta é como, se há um plano de contingência do qual o seu hospital participa, no enfrentamento de um desastre, de uma situação de múltiplas vítimas em vários pontos, para trabalho em rede, como os hospitais, como as unidades de saúde recepcionam, porque o panorama sobre o hospital é excelente. Eu tenho noção de como funciona todo o hospital, mas eu não consegui perceber como funciona a rede para atendimento em situações como essa. Possivelmente, qualquer hospital vai ter muita dificuldade se não estiver preparado para enfrentar um número
catastrófico como esse, de 200 pessoas. Aqui no hospital já tivemos uma situação assim, há muitos anos atrás, e atendemos em torno de 115 pessoas num espaço de menos de uma hora. E eu acredito que qualquer hospital com mais preparado que esteja, isso não é muito simples. Então, talvez o funcionamento de um plano de contingência em rede, talvez favoreça, eu não sei como funciona. Obrigado.
Okay. Thank you for the question. I will try to answer. So, not speaking about mass casualty, every day in my department, the surgeons are there. Okay. Can you hear me? Oh. Can you hear me now? Can you hear? So every day in the regardless the mass casualty, the surgeons are there. Okay, we have usually a junior surgeon inside the department. It's important that they come and we work together. At night after 11 o'clock, I don't have. I have only one emergency medicine doctor, so the everyone will comes with a abdominal pain. I still have two surgeons residents in the department that see these patients. But during the day, if any patients come with a recent surgery or mainly these patients, I usually don't want to see them. They have to be referred for the surgeon because it could be a complication of the surgery, etc., etc. But the rest, if need a CT scan, need to be done ultrasound, we usually do this evaluation. And whenever we are concerned or we have appendicitis, for example, or abdominal pain that I'm not sure where its origin or any surgical consultation that I need, they are there. There is a resident on floor 24/7, and there is a senior on call 24/7. Major trauma, they are there. Okay, so this is how it works in the everyday. Regarding mass casualty, there is mass casualty. I have a different talk for about really 1 hour, which is really interesting. But mass casualty, it's basically from the beginning. If there is a mass casualty event, we have to declare first. We have to verify. This is one of the first steps. If there is a mass casualty event, as a hospital, I have to verify what is the mass casualty event, what are the numbers, what is the nature of the accident that happened, and what are the numbers. And according to the numbers, usually we activate the mass casualty. If a hospital like my hospital, which is not only trained to have a mass casualty, we have to be accredited every year. The Ministry of Health, they come, they do drills, and they have to look at the different aspects of the capability of this hospital to accept patients. So if we have a storage room with for example, a storage for up to 200 Kremer casts for orthopedic injuries, or except, so it's a one big hall with a storage that need. We have a nurse and a doctor in charge of the mass casualty events, disaster medicine in the hospital, and this is one of the rules. Check the storage room, make sure that the hospital is accredited, make sure if we want to be in the JCI, we are doing the JCI for the hospital. I have to make my staff, surgery staff, and all the needed staff trained, drilled, or at least I have a theory part once every 6 months. But if the casualty, and what happened is basically usually most of our casualty, the maximum that we have seen in the last 5 years is 65. 2 years ago, what happened is we evacuate the department, the emergency medicine department. Evacuation is not easy because some of the patients still are sick. So what we do, we have a checklist. We declare a mass casualty event through the emergency medicine director or the doctor in charge, through the director of the hospital. We once activated, we evacuate the emergency medicine department. There is a senior doctor mainly emergency doctor, physician. He is in charge only for this evacuation to make sure that these patients are safe to be gone to other departments in the hospital. And in every unit, we have doctors in charge. Usually in these events, you will have many staff. We never had a problem with staff. People will see the message, and also we have a well-controlled system, because if it's up to 20 20 casualties, this is still, it goes through phone calls through the secretary or the navigator center that I have in the emergency department. They have to go through the checklist for, I would say, specific head of departments, specific rules of physicians, and they make the phone calls and they bring them from home. Depend what time of the day the mass casualty happens. But if we know from zero time that the mass casualty is big, or it could be above the capability of the hospital to receive, we have immediately, we open, it's not in the floor for the emergency medicine department. In the second floor, in the management department, we have a room, which is the control room, which is specific rules. The vice director or the medical director of the hospital, or the medical director of the hospital, or the director of the disaster medicine in the hospital, with the doctor, with the nurse, with representatives from the pre-hospital MADA, which usually they bring the patients, with Ministry of Health hotline immediately. And the most important thing here, this is now not the level of me deciding where the patient goes. This is, we have the Picot d'Orif, which is the workforce, the military workforce. The military workforce, immediately, they usually involve the first, when there is an event, usually the first forces that they go there is the medical forces, then the police, more or less, because they are usually available. But then immediately there is the right after there come the military workforce, and this is now in the military workforce together with the hospital directors. They do evaluation of the scene and they speak up what should be done, where we should transfer the patients. Okay, the event that you saw in North Israel with 200, it's a total disaster. But you can imagine what happened is, we don't usually, by the way, use a lot of helicopters in mass casualties in Israel. The distances are small, and there is a lot of hospitals, 10, 15, 20 minutes drive. Not of course, not of them are tertiary medical centers. But this hospital, which was a non-tertiary medical center, found themselves are going to receive this huge number, which is, it will not happen, right? Immediately it will turn into a triage hospital. It means that some of the military workforce immediately there, they will decide that the patients that they looks non-critical situation now, and they could be transferred, they will put them on a big chopper, that like the one that you saw in the picture, and they will transfer them even to Hadassah. It's only 15 minutes or 20 minutes flight. So they would turn this small hospital, which has a capability only for 50, but they know, they estimate 150 to 200. So the critical ones that they need urgent care, they put them in this hospital. The rest, they would transfer them to other hospitals immediately. This is what they do. A big hospital like us, usually we never had a problem. We never converted patients. So we had event about 15 years ago where there was a wedding, big wedding of 1,000 patients, collapsed, one floor collapsed. It's called Versailles crisis. And we had more than 100 patients come to our hospital alone. So it's a chaos, but once if the level it's a little bit above the capabilities of the hospital, it's a big room with Ministry of Health with mainly military workforce, and there they can divide the patients flow to different hospitals, different places all around the country, not necessarily to the closest place. Did I answer? This is, thank you. One more question?
Good morning, Ron. Thank you for being here. My name is Ed. I'm here at the hospital.
ENT?
ENT. And I had two questions. First, about the population. You guys have how many people are in the coverage? And the second question is about the qualifications of the emergency service. After you guys started the specialty in the hospital, how the qualification and the results in the patient's outcomes, is that better? Do you have numbers on that?
So, what was your first question?
The population.
Population. So we are a small country. We Hadassah, it's located in Jerusalem, where we have 600,000 population, but we give a service for Jerusalem and around Jerusalem about 1,200,000. So this is more or less the amount that we have access. We do have a Mount Scopus hospital, which is in north or eastern Jerusalem a little bit, and 2 months ago we opened another arm for the hospital. It's in a near city. It's called Beit Shemesh. This is give us also the opportunity to treat another 300 to 400,000 or access to 300 400,000 patients. Regarding qualification, I don't have I'm not sure if there is a numbers that can show treating a patient with emergency access as first is better than why. Okay, I don't have, but what I do have, or I will have even better for next year, is basically I can see time the patient arrival until they see a doctor. This is something that today we are in 1 hour average, 1 hour 20 minutes. It's average for emergency medicine doctors to see. This is definitely need to be less than 1 hour as an average, but it's a big work. It's not easy. Some of the departments, they see the patients, if I look retro, after 2-3 hours. Okay. And by the way, there is also have been some revolution in medicine. For example, in my institute, the cardiothoracic surgeons, they are great. They want to see the patient after diagnosis. He doesn't really care if they hit their chest. If there is rib fracture, I want to know. If there is pneumothorax, hemothorax, please. If there is a major trauma that need the open thoracotomy, they will run. But you know, they don't want these patients or the urologist. I mean, they don't want to see every time flank pain, but it could be back pain, and it could be also some internal hernia. So it's becoming that, you know, the specialties, they more want the more clear view what exactly you want from them. They don't really like to investigate. They want to operate. They want to have, like most of our junior surgeons that they come to the emergency department. For them, if I see the patient, I already did the diagnosis and give the patient with appendicitis, MPO, fluids, antibiotics. Perfect. This is what they want. Most of them, I would say. Okay, but in the trauma, they are there. In the mass casualties, they are there. So it's just dividing. It's different. It just, of course, some of the departments like it more, some less. More questions?
In the 90s, in Paris, there was this care accident. They died. And there were criticisms of the way she was assisted. states that back then had the states strong supply. Do you think nowadays the chance of surviving would be better than the ones you had at the time of parents?
You're asking me if I just want to clarify the question that if there is.
In general, emergency, this kind of emergency are better treated nowadays than we had
In the
30
past?
years ago.
I think yes. I think
The logistics are very
today